Dear colleagues, good morning. It's a pleasure to announce Adak Asdash. Adak is a second-year resident in our clinic, and in today's lecture, she will take us into the world of diverticulitis. Adak, please.
Thank you very much, Dr. Dinschler. Good morning, everyone, and welcome to my today's presentation on diverticulitis. First of all, I would like to give you a quick overview about the epidemiology, risk factors, and the development of diverticulosis and diverticulitis. Then I will continue with the symptoms and the complications, also the diagnosis, and end my presentation with the classification and the therapy. So first of all, we have to differentiate between diverticula. On the one hand, we have a true diverticulum, where there is an outpouching of all layers of the colon wall, so the mucosa, the submucosa, the muscle layer, and the serosa. And on the other hand, we have a false diverticulum, where only the mucosa and the submucosa is herniated. In this situation, we have in a diverticulosis. So in the diverticulosis, arteries penetrate the colon wall to supply the mucosa. And in this situation, we have a site of weakness. In the sigmoid colon, we as well have the highest pressure due to the smallest diameter. So when we have an increasing intraluminal pressure, for example, due to constipation, the herniation is easily formed of the mucosa and submucosa, resulting in a false diverticula. Diverticulosis is a disease of the older person. So in the USA, 50% of all individuals older than 60 are diagnosed with diverticulosis. In Europe, 50% of all 80-year-old individuals are diagnosed. But in the US and also in Europe, typically the sigmoid colon is the site where we find the diverticulosis, whereas in Asia we find it typically in the cecum and in the ascending colon. There are different risk factors. Some of them are modifiable and some of them are non-modifiable. So non-modifiable, we have the age, as well the genetic predisposition. Modifiable are lifestyle factors such as lack of physical exercise, smoking, which increases the risk up to 30%, or the BMI of 30 and higher, as well as the low fiber diets. So in diverticulosis, we have the presence of diverticula. In the vast majority, it's absolutely asymptomatic. Whereas when it becomes symptomatic with pain and also bleeding, we have a diverticular disease. And it's important to know that the diverticular bleeding is the most common reason for lower GI bleeding. And this is due to erosion of the blood vessels. So concerning the development of a diverticulitis, we find bacteria in the diverticula that could lead to inflammation. Another theory as well is that the fecal material blocks the site of the diverticula, causes an ischemia, and then subsequently an ischemia-derived inflammation. But as I said, it's theories that are unproven yet. Regarding the symptoms, we find acute pain as well as fever, and we can also have stool alterations like diarrhea or obstipation. It's even more important to find the right diagnosis when you know what kind of complications can occur. So we have, as I already mentioned, the bleeding, as well as the abscess, which is the most common complication, up to 70% of all complications. The perforation of a diverticulum, leading to a peritonitis. And when you have a chronic diverticulitis, you can have or develop a stenosis, or as well, fistula, for example, colovesical fistula, leading to gas in the urinary tract and a so-called champagne urine. The diagnosis is actually not very hard to make. So you know that the patient has acute pain, fever, you do the physical examination, you also ask for the medical history of the patient if he tends to have obstipation, or if someone in his family has diverticulitis or diverticulosis. Then you do the CT scan and you have the diagnosis. Also in the blood results, you can find elevated CRP and leukocytes. There are different classifications of diverticulosis and diverticulitis. In Germany, we rather have the classification of Hansen and Stock, whereas the modified Hinchey classification is more predominant in the USA. It's important to know that the Hansen and Stock is not 100% detailed. Some parts are missing here. And as well, in the modified Hinchey classification, it actually focuses on the intraoperative site and does not focus on, for example, uncomplicated diverticulitis or the chronic diverticulitis. So there is a new classification published by the German guidelines in 2014 that shows a better differentiation. It combines both aspects, the aspects of both classifications, and completes the missing aspects as well. And a very strong advantage of this classification, of this new classification, is the possibility to derive therapeutic strategies. This classification is called Classification of Diverticular Disease, abbreviated CDD. Okay, now to the part of the therapy. When we have an asymptomatic diverticulosis, no therapy is needed. As I said, the vast majority of the patients is completely asymptomatic. In case of an acute uncomplicated diverticulitis, we can administer antibiotics, but also when we have, for example, a good compliance of the patient, a mild diverticulitis with low CRPs, we can go for no antibiotics. This was shown in a paper published in 2019 in the Journal of Gastroenterology. There were two multi-center RCTs, in total 32 centers with 1,200 patients that all had CT-proven uncomplicated diverticulitis. The follow-up was 6 months to 12 months. And there were two groups, one who had antibiotics and the other group who was administered intravenous fluid alone or placebo. And there the results showed no significance. The antibiotics neither accelerated the recovery nor did it prevent the complications or recurrence. So in an acute complicated diverticulitis, we do have the indication to apply antibiotics. In case of an abscess of 4 centimeters or bigger, we can go for an interventional drainage. And in case of a free perforation, we have the absolute indication to do an emergency surgery. And this comes up to 25% of the cases. Okay, so let's take a look at the CT scans. Maybe many of my colleagues can tell me something. What do you see?
So there's a thickening of the wall of the colon and I think also free air in the abdomen.
Exactly. We see free air, we see a thickening of the colon wall, exactly, and diverticulum. So in this case, we have a free perforation and a peritonitis. Here we have the indication for an emergency surgery. Before therapy, we know that we go for colonoscopy because it is the modality of choice in diverticulosis. Do you know when we do it and why we do it actually? And do you know an important contraindication for that? Okay, so we do it 4 to 6 weeks after the inflammation. Why do we do it? We want to rule out any malignancies. And it's very important to not to do the colonoscopy in an acute situation, because in an acute situation, we have a very high risk of perforation. So when we do an emergency surgery, we do not go for colonoscopy. It doesn't have a consequence anyway. So there are different kinds of surgery strategies. First of all, we can do a resection of the diseased colon and do a primary anastomosis with a protective ileostomy. On the other hand, we have the Hartmann's procedure. Here we also do a resection of the diseased colon, but here we create a discontinuity. Why? Because first of all, we have a rectal stump, and on the other hand, we have a colostomy. After more or less 6 months, you can decide whether you do a stoma reversal or not. So why do we prefer Hartmann's procedure in an acute situation like a free perforation? We choose it because it's safe. It's standardized, it's a standardized procedure. We don't have any anastomosis that can lead to an insufficiency. So this is the absolute positive aspect of the Hartmann procedure. On the other hand, you have to take into consideration that the stoma reversal has a lot of complications. And compared with an ileostomy reversal, we have significantly more serious complications. So even in 1/3 of the colostomies is not even reversed. So which procedure shall we do? There is no randomized studies, but there are retrospective studies that show a trend of parameters generally favoring the end colostomy solution. This is in case of sepsis with hemodynamic instability, or if the patient has comorbidities like a chronic organ failure, diabetes, or immunosuppression. Also, the surgeon's preference and the experience should not be ignored. Another study showed strong predictors for the end colostomy solution, which is again the emergency situation, if the patient has an BMI 30 or higher, if there is a free perforation with purulent or fecal peritonitis, or if the peritonitis index is 10 or higher. So the chronic recurrent diverticulitis is subclassified in 3 groups. First of all, we have the symptomatic uncomplicated diverticular disease, where you, as the name already mentions it, you just do symptomatic treatment with painkillers. On the other hand, the third one is the recurrent diverticulitis with complications, such as fistulas and stenosis, where you go for surgery. In the situation of a recurrent diverticulitis without complications, you really have to go individually. There is no clear guideline what to do. There is the American Society of Colon and Rectal Surgeons, as well as the German guideline that has, guidelines. They say you should go for individual therapy, you should see what the patient wants, and you should see what is best for the patient, obviously. So who and when is operated? First, we have to know that after an initial attack, up to 1/3 of these patients will have a recurrent episode, and 1/3 of those who have had that recurrent episode are expected to have yet another episode. So it's less likely. On the other hand, in case of more than 2 episodes, there is no increased risk for morbidity and mortality in compared to patients who have fewer episodes, because prior it was said that the more episodes you have, the more likely it is to do, or you should proceed do surgery. The risk of a perforation is actually, on the contrary, higher in the first complicated episodes of a diverticulitis. So for an individualized treatment of these patients, you have to take some aspects into consideration. First of all, the risks of the operative therapy, as well as the overall medical condition of the patient, the comorbidities, and whether he's in a stable status. Also, you have to think about the severity of the attacks, and in how far the patient is affected in his lifestyle. Because sometimes patients are okay with the diverticulitis, they have mild diverticulitis, and they say, no, I'll take the antibiotics for some days and I'll be fine. Other patients feel frustrated and would like to go for surgery. Also, the fact of the inability to exclude a carcinoma is a trend to go for surgery. Last but not least, we have the diverticular bleeding. I told you in the very beginning, it is the most common reason for a lower GI bleeding. It is due to the erosion of the blood vessels. And normally it stops spontaneously. If it does not, you can go for interventional therapy. If the bleeding is severe and the patient is really at risk, you can see whether, if you find the source of the bleeding, for example, via a CT angiography, you can go for surgery and do a resection of that particular part of the colon. So as take-home messages, I would like you to know that the diverticulitis has higher incidence in patients older than 60 years. It is mostly asymptomatic. A reliable diagnosis is very simple. You have to ask for a medical history, the clinical presentation, you do a CT scan, and you have the diagnosis. The therapeutic strategies derive from the severity of the inflammation, and the new classification allows us a correct stratification. I think very interesting is the fact that an acute uncomplicated diverticulitis with low CRP, so a mild diverticulitis, can be treated without antibiotics. Free perforation demands emergency surgery. And here, in this case, Hartmann's procedure is well established. It's a safe procedure, but as I said, you have to think about the risks of the reversal of colostomy. And last but not least, the chronic recurrent diverticulitis with complications, you go for surgery, and without complications, you have to do the decision individually. Thank you for your attention.
Thank you very much. Very excellent presentation in this short time for a very frequent disease that many general surgeons will have to face many times during their career. There are a lot of beliefs here, and I am still convinced that many times this is overtreated, this disease in many hospitals, and the way to choose the treatment is to know what you've shown, the natural history, what happens if you do nothing, and then you have to choose the treatment that must be better than the natural history. So maybe I will ask the question now to Dr. Dintzler or Professor Turina, and to tell us a bit here what we are doing in the diverticulitis and mostly in the recurrent, non-complicated diverticulitis, when to operate, because individually doesn't mean much. I would like to know here in this institution.
Thank you. That's probably the most controversial question at this point. Earlier, the guidelines had stated that with more than 2 attacks of uncomplicated diverticulitis, the indication for surgery was given. Now, that was abolished in 2014 when the guidelines were revised. Ever since, the recommendation has been to find an individual, a tailored solution for each patient, and that really makes things more complicated. We have observed that we get far fewer patients that are referred to our department for that reason, because patients are being seen by gastroenterologists and primary care physicians, and they simply don't refer these patients anymore. When we do see patients, we try to follow the guidelines, so we discuss with them. And the discussion is always about risk of further episodes versus risk of surgery. And that needs to be balanced. So typically, patients with 3 or more episodes of diverticulitis, we typically do recommend the operation unless there is a high risk for surgery. Young patients, 1 or 2 episodes, we typically advise against operations simply for also medical legal reasons. There is no consensus that would support routine operations in this group of patients. However, the discussion really needs to be tailored to the patient needs. Now, we do sometimes see patients like the one we just had recently who've had 15 plus episodes of diverticulitis, who was not able to even go to the mountains for a week, for the simple reason of having been advised by so many physicians that surgery, in essence, is a bad thing for diverticulitis. So I think there is some over non-treatment, if you wish, of these patients. There's a large number of patients that should undergo surgery that are currently withheld from surgery. So difficult to answer the question. I would say as a rule of thumb, three episodes or more, low risk for surgery, we recommend surgery. Less than 3 episodes, we advise against.
I think it's very important after doing the therapy or finishing the therapy of the acute diverticulitis to take the patients into the Sprechstunde and talk with them without pressure about the different options. And it's also, I think, important to tell them that we are not under time pressure. It's not a progressing disease like cancer where we have to react now under pressure, and they have really time to think about it, what is the best tailored therapy for every individual.
Thank you, very nice presentation. I have a question regarding the perforated diverticulitis. You said that it's most commonly by the first episode, and I understand that perforated and uncomplicated diverticulitis maybe have a different pathogenesis. So how frequent is a perforated diverticulitis ever after having had an uncomplicated diverticulitis?
I think it's a question which is very difficult to answer, because there is let's say mention bias, because we have a lot of patients, they're not coming into the hospital. They are treated in an outpatient setting by their house doctors, and sometimes they even make a complete diagnosis with CT scan. They have their experience, they know the patients for years, and they treat some episode where we don't know, is this really or was this really a diverticulitis or not? So it's, I think, difficult to answer this question accurate.
But the general rule of thumb is that the fear for complicated diverticulitis should not be the driver for the indication in patients with multiple episodes of non-complicated diverticulitis. And maybe the one other statement to make is that after 2014, when the guidelines were revised, there was a study that was done in the state of California in the United States, literally 6 months after the revised guidelines. And that study actually came to the conclusion that more than 2 episodes of recurrent uncomplicated diverticulitis is the ideal cutoff for the recommendation of surgery. So we were literally back to where we were 10 years ago. And I think that's still a regimen that's done by many.
Thank you very much for this great presentation. What we observe clinically quite often is that we have patients with a very small, tiny perforation that is treated conservatively, not even with CT drainage or something like that. Is this always not always, certainly, but is this a clear indication for elective surgery once they are recovered, or do we have to treat this like uncomplicated? I mean, it's a complication.
The German guidelines is clear and says it should be operated. So there's always the wording in the guidelines. There's the wording of should versus may, sollte oder kann. But for a CT-proven episode of covered perforation, so complicated, the guideline says should be operated. So, and we follow that.
So is there any difference in the initial presentation, I mean severity in urban and rural areas? Because what I hear always is if you go to the mountains, patients come very, very late sometimes. Is anything known?
I didn't quite understand the question.
Is there any difference in the severity of the presentation or the stage of presentation in urban compared to rural areas? Because, people in the city go early, and sometimes what I hear from friends, they're really ugly presentations because there was a long delay in this population.
There's no study that I'm aware of in Europe that would have differentiated between rural versus urban patients for diverticulitis. And actually, I'm not aware of an American study either. I think for Switzerland, it will make no difference because the density of hospitals that are able to take care of diverticulitis, diverticulosis-related problems is so high that it literally won't make a difference. But I could imagine that for other countries that may, in fact, make a difference in terms of the treatment strategy, but I'm not aware of a specific study that would have looked at that. Any other question? If not, thank you very much.